I'm going to talk to you a little bit about immune-based therapies, and I'm not going to talk about them all because they're just too much and too many of them, but I will talk about a selected number of approaches, and I'll provide an overview outline of what I think we might be seeing in the future. Let's see, that way. Great. Okay, so why? Do we need immune-based therapies at all? You know, the environment is a wonderful one. Since AIDS showed up in 81, 82, things have changed dramatically. Our antiviral drugs, as you've heard today and before, are safe, well tolerated, and can be given very, very easily in one-pill-a-day regimens. Survival now can be normal or close to it, particularly if treatment is started really early in infection. We have the capability now of preventing infection through pre-exposure prophylaxis and by treating infected persons to limit the transmissibility of the virus. So the question is, why do we even need immune-based therapies? Well, there are a couple of reasons. I'm not even going to talk at all about immunization, passive or active. There's a lot going on in the field, and I'm sure you've all seen a lot of the passive immunization studies that are ongoing now to see whether or not a neutralizing antibody, when present in high enough concentrations, can prevent acquisition of infection. But I'll talk about the four other things, and those are, can we prevent morbidities with immune-based therapies? Can we prevent the of morbidities by either enhancing immune restoration to improve CD4 T cell numbers and function, or by diminishing inflammation? And these are two related but not necessarily completely overlapping phenomena. Can we cure HIV infection by application of some sort of immune-based therapies? And perhaps one of the more important things that people seem to forget about when they look at the goals is, can we learn important things that will help us understand HIV better by applying immune-based therapies? This is several curves looking at the overall decreased life expectancy in older HIV-positive persons in the antiretroviral therapy era. We do know that if we apply antivirals earlier, this decreased life expectancy becomes attenuated such that some people have a normal or near normal life expectancy. But when we look at the determinants of life expectancy, one of the things that is a contributor to a diminished life expectancy is how low you've gotten, how low your nadir was before you got started. So early therapy is undoubtedly better. And although some of these estimates that we use right now can overestimate life expectancy because of the exclusion of some individuals from studies, I think it's fair to say that CD4 nadir is a bad prognostic feature in persons with treated HIV infection, even in the current era. This is just the frequency histogram of our clinic, taken a couple of years ago, looking at how many people have CD4 T cell counts at different ranges, and these are all people who've had at least 5 years of suppressive antiretroviral therapy, and about 1 in 5 at our clinic has a CD4 T cell count that remains below 350. That was a few years ago. That percentage is diminishing because many of these people slowly rise to higher CD4 T cell counts, but this is low CD4 T cells. Failure to restore immune responsiveness is an issue among a minority of our treated patients. Who's at greater risk for immune failure? Well, late starters, obviously, if you never got to 200 CD4 T cells, if you've always been over 500, you're not likely to drop when viremia is suppressed. Older individuals are at greater risk for immunologic failure. Men seem to be at greater risk for people with immunologic failure, and duration of viremia, probably a surrogate at some level for CD4 nadir, is a predictor of individuals at greatest risk for immunologic failure. These are some data generated in our laboratory years ago, 6 years ago, where we explored people with immunologic failure in red, people who are immunologic successes in blue, and healthy controls in green. And what you can see is that the red guys, the failures, had profound decreases in the numbers of all CD4 T cell maturation subsets, naive, central memory, as well as effector memory cells. Now, one of the things that we need in order to keep up a homeostatic immune response and in order to restore immune responses is we need to have CD4 T cells undergoing homeostatic proliferation. And we can measure an index of that by looking at the frequency of cells expressing a nuclear antigen called Ki67. Ki67 identifies cells that are either in or recently were in cell cycle, meaning that they're thinking about dividing or have recently divided. One of the things that's kind of confusing is that the frequency of dividing cells, Ki67 positive cells, and these are CD4 cells only, is increased in patients with immunologic failure. So irrespective of the fact that their CD4 T cells are low, they're thinking about dividing and making offspring. And importantly, most of the cycling cells are in the memory compartment. Now, I make the point about thinking about dividing because just because you're in cell cycle, it doesn't mean that you're capable of successful division and proliferation. And we can measure proliferation, at least ex vivo in the test tube, by labeling the cells with a dye, like CFSE, a fluorescent dye, and then sitting them in culture for a while, and then running them through a flow cytometer. And if cells divide, each daughter cell has half as much dye as the parent cell. And so you can see division as movement to the left on a frequency histogram. These figures are labeled as CD71 positive and CD71 negative because CD71, the transferrin receptor, is a beautiful and nearly perfect surrogate for Ki67, which is a nuclear antigen that we cannot use for cell sorting. So if we want to sort these cells into cycling cells and non-cycling cells, we can do that on the basis of CD71. And you can see that from healthy controls, immune responders in the middle and immune non-responders on the right, the non-cycling cells don't divide. They all have lots of dye when we look at them on the flow cytometer. In contrast, when we look at the healthy controls and the immune responders, the CD71 positive cells that were in cycle in vivo in the person, because that's what they were like when we measured them, are all capable of division. They divide if you leave them alone and don't do anything to them. In contrast, the immune non-responders or immune failures, their cells don't divide. So, even though they have a high frequency of cells that are thinking about proliferation, thinking about division, they just don't do it. And this may be an important feature of their failure to respond or restore CD4 T cell numbers after viral replication is attenuated. So the question, of course, comes up. Can we improve the outcomes in immunologic failure by driving CD4 T cells into division and proliferation? And the first thing that was tried was interleukin 2, because we knew that interleukin 2 was capable of making CD4 T cells proliferate. And those of you who are old enough, Jonathan, can remember that this was a promising therapy, and we all were very excited about it. But it took 2 large trials involving 6,000 patients, SILCAT and ESPRIT, to show that despite the fact that CD4 T cells were increased by administration of interleukin 2 in cycles, there was no clinical benefit in terms of opportunistic disease or deaths. So IL-2 was not the right approach, even though we could make CD4 T cells increase. There's another cytokine out there whose development has been a little bit delayed, but looks a little more promising, at least in vitro, because the CD4 T cells that are expanded in vivo by IL7, shown here in the green, red, and blue, these are 3 different doses of drug, and the black line represents the individuals who got no IL-7. You can see that giving IL-7 in 3 times over 3 weeks, produced a dramatic increase in CD4 T cells, and those CD4 T cells looked better than the CD4 T cells that are expanded by IL-2. IL-2 seems to expand CD4 T cells of a regulatory capacity, cells like T regulatory cells. The CD4 T cells that are expanded by IL7 don't have that counter-regulatory capability, and they look a little better. But still, we don't know whether the CD4 rise that is a consequence of IL7 administration confers any clinical benefit whatsoever. And in the heart era nowadays, doing a study like that would take lots and lots and lots of patients, and the design of such a study is going to be difficult. I'm not saying it's impossible, but right now, there's not a lot of GMP grade IL7 available. A couple of companies are thinking about applying it for one indication or another, so it'll be a while before we have access to it. But something worth thinking about if you're in the part of the world where multi-drug resistant tuberculosis or extremely drug resistant tuberculosis is an issue, and this is a disorder that we know is defended against by functional CD4 T cells, you might ask a question as to whether or not there might be a role for an agent like IL7 in the management of patients with extremely drug-resistant tuberculosis. All right, that was immune restoration, CD4 cytopenia. Let's talk a little bit about inflammation. In recent years, we've recognized that sustained systemic inflammation and procoagulant and coagulopathy are part of the portfolio of activation and inflammation in treated HIV infection. And it's only worse among individuals with immunologic failure, shown here in the red, where we see high levels of IL-6 on the top left, D-dimer, a marker of ongoing thrombosis, bacterial lipopolysaccharide, not quite statistically significant, and soluble CD14, a marker of monocyte activation, are elevated in persons with HIV disease, particularly those with immunologic failure. And when we look in the lymph nodes of people with HIV disease for interleukin-1 beta, and the reason we look for interleukin-1 in these people is because we cannot measure, at least we can't measure interleukin-1 reliably in plasma, but we can find it in the lymph nodes. You can see that both in our viremic patients and our ART-treated patients, levels of this marker of inflammasome activity are dramatically elevated. And if we look at summary data shown here in the red, we have the untreated patients, and even with antiretroviral therapy in the orange, although levels go down, the lymph node levels of interleukin-1 beta are increased. Now, Giovanni alluded to this earlier, and he's absolutely right. We think that inflammation is likely to play an important role in pathogenesis of complications in HIV disease, as well as in CD4 T cell restoration failure. First, the lymph nodes of our patients with chronic disease are fibrotic. This is a consequence of long-term activation, probably mediated by elevated production of transforming growth factor beta. And one of the things that happens as a result of this lymph node fibrosis is that cell trafficking is impaired. The movement of cells inside this immunologic organ that's needed for immune function, responses to vaccination, responses to infection, as well as homeostatic proliferation are impaired. And particularly access to interleukin-7, which is expressed inside these tissues, is thought to be impaired by this fibrosis. What's more, some of the inflammatory cytokines that we can measure as elevated in patients with treated HIV infection, and those include interleukin-1 beta, interleukin-6, and interferon alpha, block T-cell responses to interleukin-7, so that even if you see the interleukin-7, you don't get a functional response, and this results in two things. One, failure to upregulate alpha-4 beta-7, which is an integrin that allows our T-cells to move back into the gut from which they've been depleted in early infection. And two, interleukin-7 upregulates expression of BCL2, which is a pro-survival factor that T cells need in order to survive the stress of proliferation. Without BCL2, they become apoptotic and die, much as we saw in that earlier slide. All right. What about, so I've talked to you about the theories and the concepts and the ideas that we think are important in terms of immunologic failure and inflammation in HIV disease. Do inflammatory markers predict morbid outcomes? Well, a number of studies have shown as much, and this is a study from the AIDS Clinical Trials Group, of which I am a member, that looked at a number of soluble mediators of inflammation in plasma and their ability to predict morbid outcomes. And in this forest plot, I think this is called, anything to the right means that your risk of getting these bad outcomes is greater with higher levels of the mediator. And the mediators that we have, I cannot see that slide yet, my eyes, but top one is IL6. The next one is IP10, which is a marker of interferon activity. The next one are the two soluble TNF receptors, then soluble CD14, then D-dimer, which is a marker of thrombosis. And the bottom one is T-cell activation that didn't seem to predict much. The reason there are two bars is that the first bar represents the uncorrected risk, and the second bar represents the risk when corrected for CD4 T cell count. So independent of CD4 T cell counts, in individuals with sustained suppression of viremia, inflammatory markers in plasma are predictive of morbid outcomes. So I call this an inflammatory soup. There are lots of different things in there, but the fact that there are lots of different things in there makes it a little more difficult to sort out who's doing what. So it's still not clear which of these mediators is driving inflammation and what is driving. It's not clear yet what are the fundamental lesions that are driving inflammation and coagulation. It's not clear yet which of these factors are causing disease, or whether or not any of them is even causing disease. Some could just be innocent bystanders. We don't even know what the actual mechanisms are that are responsible for many of these morbid events that we recognize, like cardiovascular risk, like frailty, like neurologic impairment. The actual mediators of these phenomena are incompletely understood. And we're not even sure whether or not each of these events is driven by the same mediators. It might be that cardiovascular risk is driven by one set of indices and neurologic disease by another. And the challenge that's in front of us is trying to untangle these relationships and determining who is doing what and to whom. So, just a little points to remember. When we talk about cytokines, that most of these mediators are IL-1, IL-6, interferons, etc., they're messengers. Their job in life, in health, and in disease is to, when they're made by one cell, for that cell to communicate a message to another cell. Now, they're generated locally and they work locally. We measure them in plasma, but it's important to remember that what's in plasma, it's not clear what the source of those cytokines is when we measure it in plasma. And what's more, the biologic activity of any of these cytokines diminishes by the cube of the distance from the source. So where these guys are made is where they're most active. And unless we sample the tissue to figure out what's going on there, we don't really know what these things are doing. Measuring all these guys in plasma is great. We know how to do it. It's easy. But it's hard to figure out exactly what the causal pathways are of disease when the elements that we measure in plasma are made so far away. Right. Okay, and lastly, we only measure what we measure. There are other guys out there that we haven't even thought about yet. So what are the drivers? Whom do we accuse of driving inflammation and activation in HIV disease? And the fact that we have all these culprits, all these plausible culprits of activation and inflammation only makes life more difficult. And starting up on the top left, there's the possibility that there's residual HIV production. There's probably not that much of it going on, but there probably is some expression of virus in tissues. It may not result in new infection of new cells very often, but there's occasionally expression, and we know this because we occasionally see blips in plasma. They have to come from somewhere. The middle one, HIV-associated metabolic syndromes. We measure in clinically collections of lipids, triglycerides, different densities, different sedimentation rate cholesterols or lipoproteins. How many different, I'm going to ask you a question, how many different lipid elements do you think there are in Jonathan's plasma? Pick a number. How many do you think there are? 4? 5? 20? 50? 100? Well, it turns out, Jonathan has confided in me, that there are at least 1,300 different lipid molecules, different lipid species in his plasma. Now, he didn't tell you this because he's embarrassed, but there really are a lot of different lipid molecules in plasma, and some are pro-inflammatory and some are anti-inflammatory, and we are just getting started looking at all these things. And if you want to look at the most recent issue of Pathogens and Immunity, there's a paper by Nick Funderburg that characterizes 1,300 of these lipids in the plasma of HIV-infected patients. So some of these, we know that lipid perturbations are common in HIV disease. Nick reported on that as well. And some of these are likely to drive inflammation. Co-pathogens, hepatitis C virus, less commonly hepatitis B virus, depending on where you are. CMV. CMV is, at least in our clinic, more than 90% of our patients are CMV co-infected. And CMV is probably one of the most powerful drivers of immune activation and inflammation of all microbes that we know about. Do you know that as many as half of your CD8 T cells, if you're CMV infected and HIV infected, are CMV reactive? It drives CD8 T cell expansion. So these are also plausible drivers of immune activation. Below that, we have microbial translocation. More than 20 years ago, Ron Vesey reported in the rhesus macaque model how immune cells are wiped out in the first few weeks of infection. Jason Brenchley reported the same in humans several years after that, and we've learned that microbial elements translocate from the gut into the systemic circulation, and they play an important role in immunologic activation. I talked to you about regulatory T cells. It turns out that regulatory T cells, whose job it is to restrain immunity, are impaired in function in HIV disease, even though there's some controversy about that. And finally, whenever we're cytopenic, whenever we have low numbers of CD4 T cells, we engage a homeostatic response. And some of that homeostatic response is driven by IL7. For the CD8 T cells, it's often driven by interleukin 15. And we have reason to accuse some of those homeostatic responses of playing a role in immune activation of HIV disease as well. So probably multifactorial origins of immune activation and inflammation in HIV disease. So how do we address this? And how do we address this with immunologic therapies? Well, usually when we think about a pathogenic process, our first reflex response is to block the drivers of that pathogenic process at its upstream source. But if there truly are multiple drivers of inflammation in treated infection, targeting a single process may be futile. And if we're going to design a study that targets only one of a number of drivers of activation, we may require thousands of individuals to show any sort of clinical impact. So what I'm going to propose is that it may be wiser and more effective to target the downstream mediators of activation and inflammation, if we can identify them correctly, rather than aiming upstream. And I list here a bunch of studies that have been performed and completed that have been trying to target the upstream drivers of inflammation and activation, but have not shown benefit. Sevelamer or rifaximin to block translocation of microbial products, chloroquine to block some kinds of toll-like receptor signaling, aspirin to block platelet aggregation, ganciclovir to decrease CMV replication. It did decrease activation just a little bit. We don't know yet what treatment of hepatitis C in the ART era does. I would wager that you're going to find that you could decrease immune activation, but whether that has a clinical impact on anything other than hepatitis C remains to be seen. And antiretroviral therapy intensification that did drop immune activation a bit in some studies, but not in others. So my take is, and others may disagree, that I think it's going to be rough to show that any one single upstream driver of activation can be blocked to have a clinical impact on morbid outcomes. So could we do better if we block downstream mediators of morbidity? Maybe. And I'll tell you about a couple of studies that are ongoing and cooking and you'll hear about. We just broke the results of ACTG 5314, which is a trial of methotrexate. I can't tell you anything about it because I'll be beaten up if I do, but the results are interesting, and if all goes well, they'll be presented at CROI this February or March, whenever CROI is. At our place, we finished a trial of interleukin-6 inhibition, and the reason we chose to interfere with interleukin-6 is that of all the plasma markers that predict morbid outcomes, IL-6 appears to be the most robust. I don't know anything about the results except, because we're just analyzing the data now, but I hope that the paper that we write, if we write it, does not say the treatment was safe and well tolerated, because invariably that means the treatment didn't do anything. But we should be able to say something about that in 6 months. The ACTG is doing a large trial of statins, pitavastatin, several thousand patients, called REPRIEVE. Of course, I don't know what the outcome of this study is. And not only do these drugs have some benefit in decreasing some pro-inflammatory lipids, they also block some mediators of activation, like Kruppel-like factors that play. They enhance Kruppel-like factor expression that is an anti-inflammatory element. You've all seen the results of the IL-1 inhibition study with canakinumab, the CANTOS trial done in the general population. Not only did blocking IL-1 beta cut cardiovascular morbid events by about 15%, but it also cut the mortality due to certain kinds of lung cancer by about half. And so blocking IL-1 may have some clinical utility in the setting of morbidities, including malignant morbidities in treated HIV infection. And ACTG 5366 is blocking JAK-STAT signaling with ruxolitinib, and that study is also ongoing. I'm not saying these are the only studies that are worthwhile. These are just the only ones that I can spell. And so I've told you about them. There are more cooking, and I encourage you all to think about what you might want to do in terms of interfering with host-mediated inflammation. All right, so how do we test a concept? Unless you're going to do a large several thousand patients trial, you need to have some mechanism to make a go, no-go decision on your strategy. And it's hard to know what the best interim marker should be. CD4 monitoring was probably not sufficient. We can also monitor levels of inflammatory mediators. We can also look at an in vivo marker of improved immunologic response, and I think one of the simplest ones and one of the most important ones is vaccine responsiveness. You don't have to wait for morbid events. You immunize everybody for a variety of things, like influenza every year, and you can use that as a marker of in vivo immunologic competence. Right, and it's plausible that a different intervention might selectively affect one readout and not another. Do I have a few minutes to talk about eradication? How many minutes do I have?
5-10 more.
Oh, great. Well, we're good. I can do that. All right. So, it's hard to talk about HIV disease in the treatment era without talking about cure. And, this is a barrier to cure, the presence of an HIV reservoir in resting memory cells, as first shown to us by Bob Silicano's laboratory. And this reservoir of replication-competent virus within quiescent memory CD4 T cells has a very, very slow decay in the setting of antiretroviral therapy with an eradication time estimate, which I think is an over-optimistic estimate of about more than 70 years, which is probably longer than most of us have after we've acquired HIV infection. So what are the barriers? Well, obviously latency is a barrier. Latency means if a virus is latently integrated in the host genome, there's little death and turnover of those cells because they're quiescent. They're not thinking about doing much at all. And because they're metabolically inactive, the virus is metabolically inactive, they're poor targets for antiretroviral therapy that requires some metabolic event in order to be useful. And what's more, as Giovanni alluded to earlier, there are sites of viral persistence that may be protected from penetration by antiretroviral therapies. But not to be underestimated is the stupid virologists who can't measure replication-competent virus without exsanguinating my patients. So, I will concede they're getting a little better at this, but We're leukapheresing patients in order to get enough sample to measure eradication. And that's understandable, because if we're talking about frequencies of rare cells per million resting CD4 T cells, we're talking about having to measure lots and lots and lots of sample in order to know whether or not we've gotten where we want to be. So if we're going to talk about any treatment strategy, we need to talk if it's novel, if it's new, different. We need to be thinking about whether it's plausible, whether there's precedent, whether it can be scaled. 35 million people are living with HIV disease now. How durable the effect is if we're talking about something that's hard to measure and we're talking about inability to find something. Is this treatment tolerable, and what are its limitations? By this, if it's plausible, that means should it work? When we're talking about precedent, has it worked before? If we're talking about scalability, we mean for how many people can it work? And if we're talking about durability, we mean for how long will it work? If we're talking about tolerability, can people stand it? You know, can they manage to get by with the therapy? And of course, what are the downsides? I've listed here 8 approaches for cure. I probably should say remission, but we're still using the word cure. These are 8 strategies, some of which are a little bit overlapping. One, you've heard about shock and kill. The idea here is to activate the cell using some signal to make sure that the viral promoter is starting to transcribe enough viral RNA effectively so that we make viral proteins and get that virus to express and maybe kill that cell. It's thought by many, but not all, that a virus-expressing cell will die in time. A second approach, which is just the opposite, is to do something to the elements that bind to the viral promoter region to sort of lock it in concrete so that it cannot be activated. So it doesn't make a difference. And if you can do that durably, well, maybe that's as good as a cure. A third approach is to find a marker that distinguishes a latently infected cell from all other cells and then go after it. And most recently there was excitement from France, from Monsef Benkirani's lab, who found that looking at an FC receptor, an unusual FC receptor called CD32A, expressed on the surface of CD4 T cells might be enriched, might identify cells that are enriched for cells containing latently infected provirus. A fourth approach is to kill immune cells non-selectively. Say, I don't care what I'll just knock off all the CD4 T cells and thereby eliminate the reservoir and allow or promote in some other way immune restoration under antiretroviral therapy. A fifth approach is to mobilize antiviral defenses. A sixth approach is to target host elements that are used for persistence. It's like some of the checkpoint elements that quiet down the immune response that allow latency to persist without activation, targeting PD-1 or CTLA-4, for example. A seventh approach is to somehow make cells completely resistant to HIV, which God has done maybe 10,000 years ago, and we'll talk a little bit about that. And the eighth approach, which I really like, is to try something that you don't know how it works. I'll do that one first. Well, this is just a summary of what I'm going to talk about. I'll talk about item 3, item 6, and item 8. This is a monkey study done by Tab Ansari's group at Emory, where they took SIV-infected macaques and they treated them with an antibody to an integrin called alpha-4 beta-7. The antibody is vedolizumab, which is used for the treatment of inflammatory bowel disease. And when they did this resulted in sustained control of SIV after antiviral therapy is withdrawn. Now, the downside of this approach is that we don't know how it worked. And the investigators who reported this, said they didn't know either, but it was an interesting idea. And the possibilities are that it could interfere with viral infection of CD4 T cells, which alpha-4 beta-7 may collaborate in. It may have an effect on gut homing, because we know that integrin, alpha-4 beta-7, is one of the mechanisms by which T cells get into the gut. And there's also a little bit of uncertainty about this study because there's reason to think that the viral isolate, the MAC239 that they used, might have been less pathogenic. It's really important to do some human studies, and several of them are ongoing right now, and we should know within the year whether or not any of these human trials show promise. This is where we stand right now in terms of effective cure. You all know about the Berlin patient who was cured of HIV just about 10 years ago. And his story is fascinating. He was heterozygous for the 32 base pair knockout of CCR5, but he was HIV positive, suppressed on antiviral therapy, and unfortunately developed an acute myelogenous leukemia and failed chemotherapy. The appropriate management of this was a bone marrow transplant. And his doc, Gero Hutter, did this brilliant experiment and said, well, if I'm going to have to give this guy a stem cell transplant, why don't I find a donor who's HLA matched and has a complete knockout of CCR5, homozygous knockout, and transplant him with those cells. And that's what they did. And he required two stem cell transplants with these knockout cells. And he has been off antivirals now for 10 years. And as best as we can tell, completely cured. Nobody can find viral sequences in him anywhere where they've looked. They've looked in his meninges, they've looked in his gut, they've looked in his lymph nodes, and of course in his blood. It's now 10 years and he is cured. Can this outcome be replicated? Well, of course, people have tried. And published so far are 6 instances of individuals with disorders that required stem cell transplantation who were transplanted with CCR5 knockout homozygous cells, and none of these individuals survived, underscoring, one, the seriousness of the diseases that merit stem cell transplantation and the morbidity that goes along with stem cell transplantation. So why was Tim Brown cured? And he's open about his identification, and he's been really touring around the world talking about his experience, which I think is a fascinating story. We're going to have an interview with him in Pathogens and Immunity within the next couple of weeks that might be interesting reading. The reason he was cured is that I think 2 things happened. First, they had complete myeloablation, knocked out virtually all of his infected cells with this intensive chemotherapy and radiotherapy. And then they replaced it with a population of cells that were resistant to HIV infection. Has every virus in his body been taken away? Well, I don't know. And it's hard to know because you can't grind them up the way you can a mouse and look for viral sequences. You can only look at what you can look at. So it's possible that there are some replication-competent viruses around. But the point is that there's no place for them to go. If they experience a stochastic activation, which is what happens to memory cells, they get activated periodically by whatever happens to be the environment that's activating in their milieu, then they spread infection to other susceptible cells. That cannot happen with a CCR5 delta 32 knockout. So, can a similar effect be achieved genetically without risking the morbidity of allogeneic transplantation? Well, maybe. There are ways that we have of editing a genome, and there's CRISPR-Cas9, there's zinc finger nucleases, and the zinc finger nucleases have been in clinical studies already, and you can engineer these nucleases so that they bind to a region that you're interested in, and the nuclease itself, the enzyme, cuts up the genome, and then endogenous repair typically results in errors so that you often, but not always, have a dysfunctional genome. This is being done in several centers, including our own, where individuals with HIV infection undergo leukapheresis. CD4 T cells are enriched. They're exposed to a virus that carries the zinc finger nuclease, and those zinc finger nucleases knock out some CCR5 genes. And then those cells are expanded ex vivo and then reinfused. And the first report of this by Pablo Tebas at Penn showed that the infusion of these cells, one, resulted in a dramatic CD4 T cell expansion, which I think is likely related to the way these cells are expanded ex vivo. But if you then stop antivirals, you can see in the red the cells that contained CCR5 knockouts, they survived much longer than did the non-knockout cells. So they were relatively protected. And maybe if we can get to enough cells protected, we can actually do something useful and durable. Now, people are looking at ways to target stem cells and make their progeny resistant to HIV. Will knocking out CCR5 work for everyone? Probably not, because some viruses can use other co-receptors for entries, such as CXCR4. But knocking out CCR5 is not the only way by which you can make a cell HIV resistant. Even if we can do this, will this be sufficient to protect brain microglial cells? I don't know. And are there other sites of viral persistence? Perhaps. These are all unanswered, unresolved questions that may not be readily resolved without the kind of strategy that's life-threatening, such as myeloablation. And what's also not clear is whether HIV eradication, even if we can cure somebody, fix the residual fibrosis and inflammation and coagulation that we see in treated HIV infection. So, if we engage people in these cure strategies, a lot of people are very interested in this, and this is a high priority for many people living in the community. We have to be very careful not to promise more than we can deliver. And when we enroll patients in these studies, we shouldn't be telling them we're going to cure them. We should be telling them that these studies are designed to get us moving ahead on the pathway to eradication. And we're not quite there yet for most all the studies that are ongoing right now. One of the things that's very distressing to me as a clinician and an HIV researcher is that every other week there's something in the newspapers or TV that talks about somebody having found the cure. And my patients come to me, and my family and friends come to me, and they say, oh, you know, this is wonderful. What do you know about this? And invariably, it's just, you know, it's mindless babble. So we ought to be very careful about not letting people run amok. And every time we start a new trial, a new study that's aimed towards HIV eradication, we have to remember that the regimens we have right now are safe, effective, and very well tolerated, and life expectancy can be normal or near normal. So the bar is really high. We have to do better than that if we're going to do something more. So that's the end of my presentation, and yeah, I did go over a little bit. I'm sorry.